Hello and welcome to our TIF Talk today. We have a very special guest today, Dr. George Aragon. Thank you so much, Dr. Aragon, for being here with us tonight. We're excited to talk to you about GERD and TIF.
Thanks for having me. I'm excited.
Of course. So before we start, I do want to remind everybody, my name is Andrea Millers. I am the Senior Director for Market Development for Endogastric Solutions. And we will also have Wendy Prophet, who will be on helping with questions tonight. So you might see her pop in a little bit. If you've been watching our TIF Talks, you have seen her on before. And also, just to let you guys know, this is a live event. So if you have a question at any time, please feel free to type it into the chat section, and we will do our best to answer all of your questions. Before we start, I do want to give you a little bit of a background on Dr. Aragon. He is a board-certified gastroenterologist. He received his undergraduate degree from the University of Florida in Gainesville, where he has his honors graduate. He completed his medical school at Meharry, am I saying that right? Meharry
Yep.
Medical College in Nashville, Tennessee. He completed his internal medicine residency and gastroenterology fellowship at George Washington University. He has a special interest in treating GERD, Barrett's esophagus, internal stenting, chronic liver disease, and colorectal cancer screening. He is affiliated with Memorial University Medical Center, St. Joseph's Hospital, and Candler Hospital. So again, Dr. Aragon, thank you so much for being here. We really appreciate it, and welcome to our TIF Talk.
Thank you.
Perfect. So we're going to go ahead and start. The first thing we always kind of start to talk about is GERD. So if you could please share what is GERD and what are those symptoms that patients could potentially feel if they were suffering from GERD?
Yeah, so GERD is one of the most common GI disorders we see in our office and internal medicine clinics. But essentially, GERD is gastroesophageal reflux disease. And you can kind of break it down into your typical symptoms and your atypical symptoms. I'm sure we've all seen the commercials for Nexium and Prilosec back in the day, and those medicines have been around for almost 40 years now. So it's a very, very common condition. But your typical symptoms are the ones you always hear about. It's the heartburn, the reflux, the regurgitation, that kind of epigastric or abdominal chest burning type sensation, the acid brash type of sensation where you feel like you got that sour taste in the back of your throat. Those are your typical symptoms that most people are going to present with. And most of those are seen by their primary care doctors. And eventually, if their symptoms aren't well controlled, they get them over to GI or to sometimes even surgery. But the atypical symptoms are really the ones that are confusing to patients because they don't really know where to seek help at first. Obviously, they go to their primary care doctors first, but sometimes they have come in with a chronic cough, throat clearing, hoarseness, even sometimes you get referrals from dentists for erosions in their back of their throat and their teeth. So those are your more atypical symptoms, and they can really be difficult as far as quality of life, sleeping issues. They really kind of annoy patients greatly because they really get referred to a lot of different people. So eventually they end up saying, they're this atypical chest pain or this chronic cough is not a lung issue, it's not an ENT issue. So let's send to the GI for silent reflux, or LPR is another name for it. There's a lot of layman's names for it. So.
Perfect, thank you. I'm glad you mentioned LPR because when we have a lot of people watching the TIF Talks, one of the biggest questions is, will the TIF procedure help with LPR? We can talk about that in a little bit further.
Yeah, that's a complicated question, but yeah, I think I have some good answers for you.
Okay, fantastic. Well, before we talk about that, let's talk about what do you normally tell patients to do at first to manage their GERD? Because obviously we know so heartburn happens kind of pretty frequently. If you ask any person, they've probably had heartburn at some point, but at what point does it turn into actual GERD? And then also, what do you normally tell your patients to do if they are suffering or need to manage their GERD symptoms?
Yeah, so I mean, lifestyle and dietary modifications is a big part of a lot of different preventative medicine, but especially GERD, because a lot of the symptoms of GERD can be managed, if their symptoms are mild, it can be managed with different lifestyle and dietary modifications. GERD, like you said, is extremely common, and it's very physiologic that you get GERD if you eat a very heavy meal, or if you're eating something that's very fatty, or you ate too much food and you lay down very quickly. It's normal to get GERD, so that shouldn't necessarily alarm you. But again, lifestyle and dietary modifications, whether you get some type of anti-reflux procedure or not, is extremely important to initiate even before you think about procedures, because not only do medications help, or anti-reflux procedure helps, if you don't change those mechanisms that cause you to have GERD, then things can definitely occur down the road if you don't change those things. But lifestyle is a huge thing, and I think the main take-home lesson is you really want to avoid those big, heavy meals that we so much enjoy doing. It's such a social thing to do, is to have a nice dinner with your family and just really overeat and things like that, and then take a little nap afterwards. Yeah, I mean, Thanksgiving and Christmas, all these wonderful meals that we get to spend time with our family. But those types of meal types of things definitely increase your symptoms. So the heavy meals, the maybe drinking a little bit too much alcohol, or if you smoke, all these things contribute to that sphincter muscle, that valve relaxing, causing you to have more reflux events. Some other things that are especially common in the South: obesity. That's a big issue that causes a lot of increased reflux because of that increased abdominal pressure that's kind of pushing on that stomach and causing more reflux events. Foods do cause a lot of reflux as well too, but probably doesn't contribute as much to reflux as just that dysfunctional valve. But your common ones, your fatty foods, your spicy foods, chocolate, peppermint sometimes actually can cause a lot of reflux events. So that's kind of why they put a lot of peppermints, at the hostess station when you're leaving, because a lot of people have some indigestion symptoms, so they put peppermints at the as you're leaving the restaurants.
Never thought
But
about
it can
that.
cause reflux at the same time. So it's kind of a catch-22 a little bit.
Yeah.
But foods do play a role, but I would say a little bit more minimal role compared to some of the more lifestyle changes. So
yeah, I appreciate that. Yeah, so it's funny you were talking about food, and actually there's a question that just popped up from Sharon, and Wendy, I'm just going to ask it. I know you're looking at it too, but she says, are bananas and celery with peanut butter okay for GERD?
Yeah, I think the take-home lesson is, what I tell a lot of my patients, because it is hard to avoid all foods. I think you really want to think about foods in moderation. But celery, I forgot what the other thing was. What did she say? Lemons? Is that what you said?
She said celery, bananas and celery.
Okay.
Oh, peanut butter, bananas and peanut butter with celery.
Yeah. So celery, like fruits and vegetables, probably don't cause as much GERD as some of the heavier foods. So, I actually get a lot of reflux with peanut butter. It's probably the fat content in peanut butter more so than anything else. So I think it's not the celery and the bananas, it may be more the peanut butter. So really, when you think about GERD, I think, it's good to know what your dietary triggers are, but it's not always it's not what you think it is all the time. But I would look at more the fat content of food, if the portion size of your food as well too, I think plays a very big role that a lot of people don't realize sometimes.
Yeah, good point. So talk to me a little bit about the diagnostic testing to determine, if a patient actually has GERD.
Yeah, so I think it depends on who you're seeing first. I mean, if your primary care doctor is seeing you first, you obviously won't get an endoscopy as your initial test. But even the primary care doctors and some of the surgeons can still do some of the testing to look for common causes of GERD. So you can still get like an X-ray study called a barium swallow, where you essentially drink some contrast, a little tablet that's filled with contrast, and it goes through your esophagus. So that can look for reflux events during the barium swallow. It can look for hiatal hernias and other structural abnormalities and strictures. So that's still kind of a very good test to do, because hiatal hernias are very common and a very common cause of reflux. Sometimes you can also do testing for certain infections in the stomach, like H. pylori, which can exacerbate GI symptoms, especially GERD and abdominal pain. But once you get to the GI doctors, you've kind of already gone through those simple, less invasive things. So usually once you get referred to a GI, your symptoms are a little bit more severe. So very often, especially if they have risk factors for complications of GERD, a lot of times we'll start out with an upper endoscopy, or EGD for short, where we look inside the esophagus, stomach, and upper intestines, and we can really, again, look for certain things like damage in the esophageal lining that may be from acid reflux. We can, again, look for hiatal hernias. We can look for ulcers. We can look for strictures and treat those at the same time if they need stretching or dilation. But a lot of times, a lot of people have another condition called non-erosive reflux disease. So if you were just to do a plain endoscopy, sometimes you may miss a lot of these patient populations that have reflux or acid reflux, but their esophagus looks completely normal to the naked eye. So very often when I get referred a patient, I've changed my practice a little bit in the last few years, where anyone that comes to me for refractory GERD or just really GERD and they want another solution, I'm almost universally doing some type of pH testing. And there's really two ways to do that. The easiest way to do it, if you're going to be doing an endoscopy already, is to do the endoscopy first. And then you place a little tiny wireless probe at the very bottom of the esophagus that measures your pH or your acid level for 2 straight days. But typically we do that test if you've been off of your acid reflux medication for about a week or so. And that gives us a really good baseline level of how much acid you're producing in those 48 hours. And at the same time, you can also correlate symptoms, whether it's heartburn, reflux, cough, chest pain, and correlate that symptom with what their acid level is at that same exact time. Great test to kind of really delineate how severe your reflux is.
Wonderful. Thank you. I'm seeing a bunch of questions pop up right now. So I'm gonna defer to Wendy, if you don't mind, Wendy, to maybe get through some of these great questions that I see popping up right now.
Certainly. So first of all, lots of viewers this evening. So thanks everybody for tuning in. So regarding managing symptoms, we have some questions about, what other than lifestyle modifications can you do, to manage your symptoms? And then also, when should someone suffering see a doctor?
Well, I'll take the second question first because I think it's an easier answer. If you're suffering with symptoms, I think you definitely should see your doctor. Whether it's mild symptoms all the way to severe symptoms. If you feel like they're not well controlled, you seek out help. I think that's the main thing you can do, because a lot of the things that you may look at online or on the internet may not be that helpful for your situation. So I think, again, I think seek help with your primary care doctor. And if they can't help manage it, then get you to a gastroenterologist, or if you don't have GI in your area, then a surgeon potentially could also be helpful. But as far as remind me of the first question again.
Just when, obviously when to see a doctor, and then also, I'm going to go ahead and combine another one because we have so many coming in right now. I've been taking pantoprazole. Sorry for probably butchering the pronunciation of that. But I've been taking it for 4 years, only one in the morning, and I try to watch what I eat. Is this safe? So obviously she's definitely looking at long-term PPI use.
Yeah, so as most of our viewers probably know, there's been a lot of information out there about, what are the risks of long-term PPI therapy. And I think you really need to kind of think about, what's the reasons that you're taking it, and you really have to kind of weigh the risk and benefits of these medications. As I mentioned before, these omeprazole, Prozac was the first PPI out there, in the early 80s or so. So we have lots of good long-term data on these medications, and they are very, very safe. And you had to realize some of these studies are what they call observational studies, so it's not true cause and effect. But again, if you're taking a medication and it's controlling your symptoms, I think you should continue it, but still kind of seek alternatives to that medication. Again, lifestyle and dietary modifications can help, but they're definitely not going to cure your reflux. You probably would have difficulty getting off your reflux medications just with lifestyle and dietary modifications alone. But are there potential side effects of long-term PPI use? There probably are some. There are some concerns that you don't absorb calcium very well, so there could be some bone loss risk with that. There is some theories that you may not absorb vitamin B12 and magnesium, so there could be some issues with vitamins and nutrients that you're not absorbing very well. But overall, again, they are very safe medications. But a lot of times people don't necessarily want to take a medication long term, especially some of the younger, healthier patients in their 30s or even 20s. They don't want to be on these medications for another 20, 30 years. So they really want a solution to, really a mechanical problem. because what people don't really understand is PPIs are suppressing acid. They're blocking your proton pumps, which are the pumps in your stomach that produce acid. So there's a reason why you have acid in your stomach, and if you block that acid, there could be some potential complications. But you're still not fixing true reflux or regurgitation, because it's really that valve, that flap that's dysfunctional. So you're essentially just not feeling the acid refluxing your esophagus any longer, so you're only kind of suppressing the acid more so than actually fixing the mechanical problem, which is that valve, that anti-reflux valve.
Oh, thank you for that. I have another question, Andrea, and then we'll turn it back to you
Sure.
to continue. Weston is asking, can I get multiple diagnostic tests done in the same day? I know you mentioned the EGD, you mentioned the capsule. It says, I'd like to avoid making multiple trips for diagnostic testing if possible.
Yeah, so yes and no, kind of a little bit of a complicated situations, because most gastroenterologists do majority of their procedures in their endoscopy unit. So doing the EGD and the pH test is done at the same time, and most surgical centers and hospitals have that equipment available. When we start going down the road of true getting them ready for anti-reflux procedures, we typically do a barium swallow sometimes, and we almost always do a esophageal manometry, which is typically only offered in the hospital. I would say you probably can't get them all done at the same time, but you can get probably the most helpful test and the initial test, which is the EGD and pH Bravo test, done at the same time. And then once we get to the point of deciding on TIF or any other anti-reflux procedure, then we can get you scheduled for the manometry down the road, kind of prior, like, a week or 2 weeks prior to the procedure date.
Excellent. Okay, and sorry, one last one, Andrea,
Yeah.
because it just falls into our conversation here. John's asking, does a Bravo hurt?
No, I mean, a lot of times people will have a foreign body sensation. It's about the size of about 2 centimeters in size, so like your biggest pill, essentially. And it's attached with these little 2 pins to the very lower part of the esophagus. So it doesn't necessarily hurt per se, but sometimes people do feel it. I mean, it is like a foreign body sensation, almost like when you swallow a big pill, like you can kind of feel it go through your esophagus. So just think about that feeling every time you eat. So it's not painful, but you definitely know something is there.
Very good, thanks. All right, back to you, Andrea.
Thank you, Wendy. So let's talk about what options today are available to treat GERD, if you don't mind.
Sure. I mean, I think we can break that into medical therapy, which we've kind of talked about a little bit, and then the surgical and procedural approaches as well. So medical therapy, you really have kind of 3 options, going from mild, moderate to severe as far as which one you choose first. I'd say the most common medication we use are the class of drugs called PPIs, or proton pump inhibitors, the Prilosec and Nexiums, the Dexlants, those types of medications. But the initial acid reducing medications were the histamine blockers, which are their Pepsids and the Zantacs and things like that. So those are still used in a certain patient population, but those are more for kind of to use on an as-needed basis for just very mild symptoms, or sometimes you add it as an adjunct to your PPI therapy once you've already kind of maxed out on those, taking it twice a day. And then you still have the Tums and the Rolaids, which are more kind of antacids and buffers, but again, those are for very, very mild symptoms or as an adjunct to your other medication. So I think those are your medication options in addition to the dietary and lifestyle modifications. And then you have your procedural options. Obviously, our talk today is about TIF, which has been around since about 2007, and has been over 25,000 procedures from the last time I looked, done in the United States and I think in Canada as well. So it's very, very great procedure, and it stands for transoral incisionless fundoplication. So essentially, it's a wrap type of procedure, going back to the initial fundoplication procedure called the NISSAN fundoplication, which has been around since the 1950s. So these are all kind of anti-reflux procedures that are wrap procedures, where essentially you're kind of recreating that valve by almost twisting the stomach around the lower part of the esophagus. And then another fairly popular minimally invasive option is the LINX procedure, which is kind of these magnetic beads. They're titanium, but they're essentially magnetic beads that are sized to the lower part of the esophagus individually to each individual patient. That kind of, again, helps augment that valve, that lower esophageal sphincter. Also a great procedure, but it is a foreign body, so there is a little bit of concerns with that. It is magnetic, so there is some issues with some of these newer MRI machines that you necessarily can't get those higher Tesla MRI type radiology images. So that is a little bit of concern. And then a little bit of an older endoscopic procedure is called the Stretta procedure, which isn't done that often anymore. Definitely not done locally here in Savannah, but essentially is kind of, in a way, burning or cauterizing the sphincter, the valve area in the lower part of the esophagus to kind of help strengthen and kind of scar down that valve so it kind of closes better. But again, not used that often. But they all have kind of pros and cons, I would say. I think the LINX and the TIF are probably the more popular option, mostly because of the minimally invasive approach. The TIF, I think, has a little bit more of a pro because it's done endoscopically, and it can fix these smaller hiatal hernias, less than 2 centimeters in size, so it can all be done endoscopically and completely incisionless. For hernias that are bigger than that, then you do combine it with a hiatal hernia repair, which is typically done laparoscopically. But the LINX, again, is a great minimally invasive approach. One of my colleagues here in Savannah, Dr. Mandel, does them very often. We very often team up with hernia and TIFs as well too. But I always offer my patients both of those options, the TIF and the LINX, and I kind of let the patients decide because I think it really ultimately is their choice. I just want to get their symptoms under control. That's my main focus on my patients.
Yeah. No, thank you for that. Now you talk about, kind of the newer procedures, and then you also mentioned fundoplication. Can you talk a little bit about the NISSAN fundoplication? Because, TIF is technically, as you had mentioned, doing the same thing, right? A fundoplication. So maybe talk about the difference between the NISSAN fundoplication versus the TIF fundoplication, and maybe why you think, or maybe you don't. I don't know what your thoughts are on the NISSAN, but are there differences between the two, and are there pros and cons, versus doing one versus the other in your mind?
Yeah. So I mean, before I started doing TIF, and I started doing TIF for our group in 2018, I sent most of my patients for LINX. There was still a subset of patients that I sent for NISSAN as well too, and fundoplication is just more the general term because there are different types of fundoplications. There is the NISSAN, which is the initial one, again from the 1950s, which is a 360-degree wrap. So if you think about a clock, it's from 12 o'clock all the way back around to 12 o'clock, compared to the TIF, which is it still is a fundoplication, but it's more of a 270-degree to 300-degree fundoplication. So you kind of go from about 11 o'clock to 1 o'clock. But some of the newer techniques, we're getting about a 300-degree wrap with those. But there are other partial fundoplications that are done surgically, the door and the toupee fundoplication, which you use in certain patient populations as well. But I think really the thing that really sets TIF apart from the surgical fundoplications is its reproducibility. Since the TIF is done endoscopically, you can take someone like myself who's done less than 50 TIFs compared to a Ken Chang or some of these other guys that have done more than 200 or 500 TIFs. And if you looked at their TIFs a year out, they almost look exactly the same because it's completely reproducible compared to a surgical fundoplication, NISSAN or one of the other ones. I mean, there is a lot of subjectivity to those because they're doing it outside the esophagus. They're doing it laparoscopically or sometimes even open. So it's really based on their own experience. Compared to having this scope and the TIF device in your esophagus, you really can't wrap it too hard because the TIF device is actually pretty large. It's about 20 millimeters in size or 2 centimeters in size. So you can't wrap it harder than the actual device itself. Yeah. I'm sure a lot of the viewers know there are some potential complications with NISSAN fundoplication. And I think that's what scares a lot of people, where they really don't even want to talk to their surgeons about that or to their GI doctors about that. But there is a risk because it is a total 360-degree wrap. There is some risk that you would trap air in the stomach. So you can't really relieve that air with belching or burping. So you do get a lot more gas bloating because it is a pretty tight wrap. There is some risk of difficulty swallowing or a condition called dysphagia. There is a risk of inability to vomit or regurgitate. Not that everyone wants to vomit or regurgitate, but that is a concern for a lot of people if they get a sickness. That's why I think a lot of these minimally invasive approaches have come about, because of the concerns about the long-term complications of fundoplication, NISSAN fundoplication specifically.
Yeah, thank you. Wendy, do we have any, I see a couple of questions popping up. Do you want to get to some of those questions before we continue on?
We sure do. Since you were talking about the actual procedures themselves, we did have Sharon chime in and said that she has had TIF and also a hiatal hernia repair. So thanks for mentioning that. She's also, once we get to it, looking for diet tips. So we'll get to that in just a second. But I have an interesting question from Jason, who says, is there a limit to the number of times we can add sutures if something were to come loose, or can a TIF doctor easily add sutures every time, considering scar tissue, etc.?
I assume Jason's question is, for doing the first TIF, or I think that's what his question is if there's a certain amount.
Yes.
So let me kind of answer it in two different ways, I guess. So with the initial TIF, say they've never had any type of surgical procedure before, the minimum, I'd say, fasteners, and they're kind of like these H-looking fasteners, almost like the little tags on your shirt sometimes that you get. They kind of look like that, but a lot stronger. But essentially, we typically put a minimum of 20 fasteners, kind of creating this valve. We do 6 kind of up in the 11 o'clock area, 6 in the 1 o'clock area, and then we kind of put a few more kind of in the middle area, like at 5 o'clock and 7 o'clock, and kind of touch up. But more recently, to really create this 300-degree wrap instead of a 270-degree wrap, we've been actually placing a lot more. So I think the most I've placed myself is 26. So we'll kind of tack up the corners a little bit more, just to kind of give that omega shape, so it kind of comes around the front and the back of the valve. I've heard of other doctors in certain areas being a little bit more aggressive and going up to 30 fasteners. So I think it really is that's where there is a little subjectivity to it. You kind of just you do your 20 fasteners, then you kind of just sit back and look. You kind of look at the valve, you look at it from different angles and say, oh, I could probably kind of put a few more fasteners up there, or I think this could be tacked up a little bit there. So I think it really depends on what it looks like to you. But I think that the minimum is 20. I don't know if Jason was really alluding to this or not, but sometimes we will. I haven't done this myself, but maybe a TIF that was done 5 years ago with maybe a earlier generation of the device, you may need to be redone. So you can do that as well too. I have done a few redo NISSAN fundoplication. They've had a NISSAN like in the distant past, and then it came loose, or they started having more breakthrough symptoms. So you can add fasteners to that. So you essentially can redo a previous fundoplication, because the anatomy is already there. So essentially you're just kind of tacking it back up. So you may add another 10, 20 fasteners just to kind of tack it back up, so you kind of recreate that valve again. So I don't know if that's what he was asking, or if he was just asking, was there a certain number or not? But
yeah, it looked like he might have been talking about a bit of a revision. So
okay.
That's perfect. Thank you very much for mentioning that. John is asking if someone can have a TIF if they have Barrett's esophagus, and if so, are they done at the same time, or is one done before the other?
Wait,
yeah, that's a great.
Hold on. I'm sorry. There is a question that just came up, and Wendy from Warren asking, do the fasteners dissolve eventually or not? So maybe Dr. Aragon, you can talk about, just since we were talking about that previous.
Sure. So they don't dissolve, but if you go back later on in a couple years, they probably get more buried into the mucosa, because essentially you're tacking up the stomach to the esophagus. So right when you are down there, I mean, you definitely see them, in the esophagus and in the stomach, but eventually over time they kind of dissolve into the stomach itself, but they're not going away. Like if you were actually to open up the stomach, they would still be there, but they're just more buried down into the deeper layers of the stomach and esophagus.
Great. Thank you. Sorry, I just wanted to make sure we addressed that before you're talking about it. Go ahead, Wendy. What was you might need to repeat
John's question just about whether or not if you have Barrett's esophagus, if you can have TIF, and if so, do you have treatments at the same time, or does one come before the other?
Yeah, that's a great question, and definitely I think you would get different answers depending on your expertise in your area. So Barrett's esophagus is obviously very common and one of the major complications we look for in someone with chronic reflux. But it is a certain patient population that can get Barrett's. It's usually you're above 40 years old. They're usually Caucasian. They're usually male. That doesn't mean like your 20-year-old female can't get it, but that's who the people you screen for. And there's different degrees of Barrett's esophagus. There's something called non-dysplastic Barrett's esophagus, and there's short and long segment Barrett's esophagus. So if you have very minimal Barrett's, like it's short segment, there's no dysplasia, which is a higher risk of cancer, then I think you can kind of have a long discussion with your patient, but you could do an anti-reflux procedure on that patient. There is a concern, at least in my practice, there is a concern that whenever you do some type of anti-reflux procedure, you could potentially bury that Barrett's esophagus and not be able to see it later on because you do need surveillance endoscopies every 3 to 5 years. So there is a concern that you could potentially, bury that Barrett's and not be able to see it down the road and eventually develop cancer. So in my practice, I think I've only done this in one patient so far, is they've had long segment Barrett's esophagus, no dysplasia still. I actually sent them to one of my colleagues to get ablation to essentially burn off the Barrett's esophagus so you have a normal line in your esophagus. So essentially you're starting over again with a normal esophagus. So that's my practice personally, that I think you should get rid of the Barrett's first before you do an anti-reflux procedure. But I know a lot of other people across the country will do the TIF, or a fundoplication procedure on someone with Barrett's. As long as the big thing, as long as there's no dysplasia and as long as it's short segment. If it's involving half of your esophagus, or if there's dysplasia, you really should treat that more aggressively before you do an anti-reflux procedure.
Very good. Thank you so much. All right.
And one caveat on that, this is more GI, not TIF related. We've noticed that people that had ablation of their Barrett's esophagus, a lot of times they stop their acid reflux medication after they've had ablation. So those patients, we've seen their Barrett's come back very easily, or more frequently, I should say. So I think it is a good thought. If you're going to treat Barrett's, you want to treat their reflux. Essentially, is a take-home lesson. So I think TIF is a very good follow-up for treating Barrett's and reflux. But again, in my practice, I would treat the Barrett's and eradicate it or get rid of it before I would do an anti-reflux procedure on them.
That's a good point. Yeah.
So Warren actually had one other quick question just about the fasteners that you talked about. He wanted to know if they are metal.
No, they are. I believe they are Prolene, which is like a hard plastic.
Yeah, we answered it for Warren.
Yeah.
I don't know if you saw that, Wendy.
I did. Just wanted to make sure it was on the audio too, just in case people couldn't see the comments.
Gotcha.
And then last but not least, and we'll turn it back over to you, Andrea, is Vic is asking if erosive gastritis and esophagitis can be healed.
No, definitely they can be healed. So we have a lot of really great studies that erosive gastritis is a little bit different mechanism of action, but erosive esophagitis, which is typically from acid reflux, can definitely be healed with PPI therapy or acid reflux therapy. It takes about 3 months or so to heal, so you want to be on high dose acid reflux medication for at least 3 months. If it's very severe, a lot of times we'll go back in 3 to 6 months to make sure it has healed though. Because we typically do not biopsy when it's very severe. So we always want to go back later on, make sure it's healed, but also to rule out Barrett's esophagus down the road. So erosive gastritis typically is not from acid per se. It's usually from medications like NSAIDs, which are like ibuprofen, Motrin. Sometimes it can be from infections like H. pylori. That can heal also, mainly through the same mechanism, but it's not acid that's causing erosive gastritis.
Thank you so much. All right, back to you, Andrea.
Thank you, Wendy. Okay, let's talk about recovery. That's one of the big questions about the TIF procedures, the diet and post-op. What can they do? And I think maybe you were discussing it earlier about, when you build the wrap, and even if they get a hiatal hernia repair, you don't want to disrupt that for a period of time so it can heal appropriately. Can you talk a little bit about what is expected of a patient after they either have the TIF procedure and or the combination procedure with the hiatal hernia repair and the TIF?
Sure. So I think that's really the benefit of straight TIF, especially, is that the recovery is so great. You can have a 23-hour observation in the hospital, so it can be overnight. But typically what I like to do, if my schedule allows, is to do it first thing in the morning, first case of the day, 7, 8 o'clock in the morning, and reevaluate them at the end of the day, 4 o'clock, 5 o'clock, and hopefully discharge them home. I always give them the option. You can stay till the next morning, and I'm happy to discharge you then. But most patients would much rather sleep in their own bed instead of sleeping in a hospital bed. But the straight TIFs can typically go home definitely within 23 hours, hopefully, within 8 to 10 hours, though, if they get done early. We try to get them on clear liquid diet very, very soon as they wake up, and as soon as they're, as soon as they're alert enough to drink. So we want them on clear liquids very soon. But you got to realize, we are recreating this valve. So there's a lot of edema, a lot of swelling in the lower part of the esophagus. So it's going to hurt a little bit when you start advancing your diet. And if you advance it too quickly with solid foods or really big meals and big portion sizes, you could potentially, not really disrupt the valve, but you could definitely stretch it out where it doesn't heal and scar down appropriately. So you really want to kind of follow the diet that, for the TIF diet specifically, where essentially you're on clear liquids for, I'd say, 3 to 5 days, maybe up to 7 days, depending on how you're feeling. And then that week 2 to week 4, you can really start more of a yogurt, your smoothies, some kind of more full-bodied soups and things like that. And then, I think it varies from week 4 to week 8. Some doctors will progress them a little bit faster to a more of a soft mashed puree diet sooner, like in week 3, week 4. I think you had to kind of individualize it and see how they do. I think that first 4 weeks is really important, because I think you are, as we talked about before, you're really trying to change their lifestyle. You're trying to make these lifestyle and dietary modifications pre-TIF, so they continue with it after TIF. Because it is a lot about portion control and really grazing throughout the day. Eating kind of 5 to 6 small meals throughout the day, eating healthy portions, keeping the fat content down in food, keeping the caffeine content down in your food. The alcohol, smoking plays a big role in reflux. So you want to institute these things prior to their procedure, whichever one they choose to do, so they kind of stick with it. But you can almost definitely guarantee you'll lose some weight in that first 8 weeks. I mean, most times I'd say 10 to 15 pounds or so in that first few weeks.
Fantastic. And what about exercise?
Yeah, so thanks for reminding me of that. So exercise, I think, in that first week, you really want to limit exercise, and definitely limit the lifting and anything that's going to increase abdominal pressure. So you want to kind of keep your lifting of probably less than 5 pounds in that first week. But most people, if they have a pretty office type job, they can return to work within 3 to 5 days typically. You can still do very well with the liquid diet and maintain your calories and things like that. But you want to kind of limit the really strenuous exercise or the heavy lifting for at least 4 to 6 weeks. I definitely would not overdo it, because you really want to make sure that TIF or hernia repair heals appropriately. I think the recovery from doing the concomitant hernia and the TIF are about the same, at least in my experience with Dr. Mendel. All the patients have recovered in the same form. He does a great job. He does all of his done laparoscopically, takes about 30 minutes, and they do great, when they do the hernia. And it makes the TIF so much easier once that hernia is fixed. So
yeah, wonderful. Thank you. Well, that is all we have, unless Wendy, and before we conclude, I want to give you an opportunity. Are there any other additional questions that have popped up?
I did have one other, and it was from Vic as well. It just said, I feel my symptoms get worse when I'm on PPIs. Then I stop them and begin to feel better. Is it possible that I have low acid and PPIs are making it worse?
Yeah, that's a good question. I wouldn't say that PPIs are making your symptoms worse. I would probably ask the question back, what are your specific symptoms? Because not all reflux is acidic. There definitely is bile reflux or non-acid reflux. You can have the exact same symptoms as someone with acid reflux would have. the heartburn, the reflux, the regurgitation, it's the same exact symptoms. So I'm not sure if the PPI is actually making Vic's symptoms worse, but I think maybe he needs to explore what they are. And like that, what I would probably do, if he were to see any of my group, would be, again, to do an endoscopy and do a pH test off acid suppressive therapy. I don't think we utilize the pH testing often enough. I think it's a very valuable test to really distinguish the symptoms. Because again, most of the patients we see aren't coming in with the typical heartburn symptoms.
Right. One other one, sorry, this one came in early and wanted to save it until later, was I just want to know if the TIF procedure is good for LPR and sore throat. My wife is a teacher and has LPR that her ENT says is from talking through a mask all day.
Yeah, well, I don't think I want to broach the mask debate yet. I'm not well versed enough on that one, but LPR is really difficult. It's one of the most frustrating things for patients and for providers, because I think a lot of patients feel like a lot of their doctors are giving up on them, and they get referred to a lot of different specialists before they end up seeing GI. So a lot of times, probably the first place they see is, depending on what their symptoms are, throat clearing, chronic cough, asthma, things like that. They typically see either pulmonology or ear, nose, and throat, or ENT. So very often those specialists will do a quick laryngoscopy where they go through the nose and put a little thin, tiny scope and look at the back of the vocal cords or the larynx area, and they see a lot of redness or irritation there. And they say, oh, this is probably LPR, this is probably laryngopharyngeal reflux. The acid is so bad where it's coming up above the esophagus and down into the airways and vocal cord areas, irritating it. It's a little bit hard to prove just because these are, kind of secondary signs of reflux. So really in those patients, I think that the main thing I can help, or any of my doctors can help with this diagnosis, is do an acid reflux test. And do an acid reflux test on, have them stop their acid reflux medication for at least 7 days prior to the procedure, and really find out, are they have just horrible breakthrough acid reflux. And I think the other thing that can also be helpful is, how we talked about earlier, is you can correlate the symptoms and the probability that those symptoms are related to acid reflux. It kind of computes a score. So every time you have a cough, you can essentially see, is that pH in the esophagus acidic, and correlate that symptom with the score of their pH. And I think those people that have a high symptom association probability of that symptom, that LPR symptom, those are the ones that are going to benefit the most with an anti-reflux procedure. Not just TIF specifically, but any reflux procedure will help that.
Great.
Thank you.
So if that patient hasn't seen a GI, I would push, or I'd stress to him or her that they really should do some type of pH testing, because we see a lot of post-nasal drip, a lot of allergic rhinitis, a lot of these kind of ENT symptoms that exacerbate a lot of these throat clearing, especially the throat clearing, the hoarseness, the mucus in the throat, the chronic cough, are actually coming from above the airways, not coming up from the stomach. So.
Thank you.
Yeah.
All right. Well, before we conclude tonight, Dr. Aragon, I want to just give you the opportunity, if we've got people here that are, obviously we do, suffering from GERD, what would your words of advice be to them, if you had any?
Yeah, well, thank you. I really appreciate this opportunity, but I think the main thing for patients is, before I started doing treatment for GERD, I was lumped in the same category as my colleagues and some of my primary care doctors. I was just trying to do like significant preventative things like lifestyle and dietary modifications. We had them on double dose PPI therapy, sometimes adding Pepsi at bedtime, and they were still miserable. Still a lot of our patients still have significant symptoms. So I think what I really would want patients to know is that there is solutions. If you're really not getting to where you need to be with your own doctor, kind of push the envelope a little bit. Find out, are you a candidate for LINX or TIF or even a NISSAN? Do you have a hiatal hernia? Have you had pH testing or acid reflux testing? Kind of push the envelope a little bit. Don't kind of be satisfied with, you're going to be on PPI for the rest of your life. I think that's where we haven't given our patients enough options to really fix the problem. And I think really the problem is understanding why this valve isn't working. PPIs are still very good, very safe medications, very effective medications, but they don't really fix what the problem is, which is that valve. That valve is incompetent, whether it's from a hiatal hernia or just due to aging process, but you're never going to fix that valve with medications, unfortunately.
Perfect.
And now we have great minimally invasive approaches to fix it. So
yeah, that's good. Very good point. You're getting lots of thank yous, very, very helpful to them. So Vic is saying very helpful. Thank you so much. So this is, one of the great things about doing these TIF talks. The ability for potential patients to ask questions directly to you, to the doctor, and then you give the perspective. So we can't thank you enough for joining us. But before we do so, give a little, if you are watching and you're in Savannah area, Dr. Aragon, how can they reach you, or where can they find you?
Yeah, so I think our website is on this Facebook Live thing. So that's savannahgi.com, but we have 3 offices in kind of the area, in the Lowcountry area. Main office is in Savannah. We also have an office in Pooler, which is a huge growing area if you guys don't know this area, but Pooler is ginormous. But then we also have an office in Bluffton. I don't personally go to Bluffton, but one of our colleagues does go up there, and she sends me a few patients from the Bluffton area. But we're really a unique area in this low country area because we have patients coming all the way from Brunswick, all the way out west to Dublin, Vidalia, even Macon sometimes, all the way up to Beaufort north of us. So we really kind of have a huge catchment area. So we're really serving a much bigger population than just Savannah and Chatham County. So we'd love to see you. And there's 9 GI doctors in our group. So any of us would be happy to see you.
Fantastic. And if you're not in the area, you can go to gerdhelp.com. That is our website that talks all about GERD and the TIF procedure, that you can learn more about that. But there is a physician finder locator on there. You can put in your state or your zip code, and you'll be able to find a TIF trained physician in your area. So again, Dr. Aragon, we can't thank you enough for joining us this evening. We really appreciate it. I know everyone's saying thank you. You can't see it, but they're all thanking you for all the information. We really appreciate it here at EGS, so thank you. And for all of you watching, thank you for asking your questions. You can catch us. Actually, I'm not sure we have a TIF Talk next Tuesday, but the following Tuesday we will have another TIF Talk. So please feel free to join us and get ready with your questions. Until then, we'll take care and have a great evening.
Thank you very much.
Thank you.